Hello, everyone, and welcome to our September Coast to Coast Prostate Cancer Support Group meeting presented by Prostate Cancer Foundation BC and our support initiative, Prostate Cancer Support Canada. I'm Rochelle, and I'll be moderating this meeting today with Maya, my colleague in support services. So first off, I just want to thank all of you for joining us today for Dr. Morris's presentation, Prostate Cancer, Why We Still Lack Answers to Important Questions. Before we get started, a few housekeeping items. Mics will be muted during Dr. Morris's presentation, but please feel free to send in any questions via the chat if anything comes up during the presentation. Following the presentation portion of the meeting, there will be time for a Q&A period. If you'd like to ask a question, please raise your hand using the raise your hand function on Zoom, which, depending on what type of device you're joining us from today, can be found either under reactions or participants on the Zoom toolbar at the bottom of your screen. When you click raise your hand, we'll see that you have a question and we'll call on you to unmute yourself to ask your question. After the presentation and Q&A, we should have time to move into our support group meeting and sharing session in the breakout rooms that you chose when you registered for this meeting. Please note that the sharing portion of this meeting is confidential, and any personal information that's shared here today should not be shared outside of this group. The first half of the meeting will be recorded to share with others who are not able to attend today, and videos can always be found on our website at prostatecancerbc.ca or prostatecancersupport.ca. But the recording will be shut off following Dr. Morris's presentation to encourage free and open discussion, as well as to protect the privacy of all of our participants. A final reminder as well that the facilitators, moderators, and participants today do not provide medical advice and rather are here to share their experiences. As always, the opinions and information that are shared at support group meetings do not replace the advice of a medical professional. And with that, I'm going to pass it over to Maya to introduce Dr. Morris.
Hello, everyone. So Dr. William James Morris worked as a radiation oncologist at BCCANCER from 1991 to 2019 and taught as a clinical professor in the Department of Surgery at UBC. He continues to work post-retirement as an unpaid research assistant at BCCANCER. Dr. Morris was the co-founder and head of BC's Provincial Prostate Brachytherapy program from 1997 to 2008. He co-supervised several master's and doctorate candidates in medical physics and electrical and computer engineering. He's a co-author of about 300 peer-reviewed publications with over 6,000 citations to date. He is the creator and principal investigator of the ASCENDE-RT randomized control trial and co-author of the optimal trial for unfavorable risk prostate cancer currently occurring at VCC. He also serves as the volunteer medical advisor to Prostate Cancer Foundation BC and its board. And without further ado, I'll pass it over to Dr. Morris.
So I guess we need to do the share screen thing. Is that right?
Yes, please.
So I look here and I go, that's me. I go to there we are, I think. Let's hope this all works out. Give me a moment. Thanks for that introduction. I'm actually just another old fart, was retired and not doing much of anything. If you ever want to look for my publications, and I doubt very much that you would be that unwise, you would look under W. James Morris, because it turns out that Morris is such a common name that you just end up with a bunch of people that aren't me at all. Not that, well, it might be a lot better though, right? Anyway, when I was still working, and I used to go and visit prostate support and awareness groups in the Lower Mainland, and would often be invited. I owe those invitations, because I'm very pleased to be here, to Len Gross, really, who sort of, I think we all know, is like the founder of many things. But those talks were, they were, didactic. They were full of charts and figures and graphs and, and details and, all that sort of thing. And this is meant to be much shorter, actually. And then just one other caveat here is that I kind of invited myself here, so we need to think about, or you should think about it. I'm only going to be able to get around to sort of presenting any details on just a couple of the many, many answers we don't know or many questions we don't know the answers to. And I'm kind of interested in this, and I would come back and tackle a different question, assuming there was any demand to do that. On the other hand, if this is really, really not what you're interested, you will not hurt my feelings if I never get invited back. So don't worry about it. I'm absolutely fine with that. Well, what question are we going to ask? Well, the question for today is, this is how it is often asked, or PSA groups often ask me, is universal PSA screening a good idea, or do you support it, or whatever? And I just want to say that's a really poorly framed question, because I don't even know what good idea means in that kind of setting. It's just not the way to frame the question. I think what people are really interested in when they approach this subject is, why is it that universal PSA screening is recommended by some, very trusted experts and organizations, and discouraged by other equally competent and trusted experts and organizations? So that's kind of what I'm interested in. So that's going to be the main focus of things, but it'll take me a little while to get there. Now, I'm this kind of person who's trained myself to think in numbers. And it drives my wife insane, because, every time she says something like, well, that was pretty close, or we got a whole bunch of this. I said, well, how much? She said, well, a bunch, what's the matter with you? I mean, a lot, and I'd say, well, yeah, but was it in pounds? And, I just never get a good answer. So that's just me. That's how I kind of operate. But most people aren't like me. And which is certainly a good thing. And most of us think in terms of stories, of narratives, of basically stories. So in order to make this a little bit more understandable, let's start with a story. Let's start with an individual narrative. And this is the case history of patient X. Now, it's a real person, but of course, there's nothing that will identify him. When I first met X, the year was 2005, and he was 68 years old. But his story began 10 years previously, in 1995. And it's kind of an interesting story. He fractured his leg getting into a Zodiac on an adventure cruise in Antarctica, right? Hard luck for him. And, it was a bad fracture. He had to be medevaced out to his hometown. And while he was having after he had his orthopedic surgery, his surgeon was a friend of his, said to him, man, while you're in hospital, you want us to do any tests or, anything like that? And he said, I've always been kind of curious about this PSA, maybe you should do that. So they did, and it was elevated at 7. And it was repeated, and it was 8.2, and he was referred to a urologist, and his digital rectal exam was normal, and he had a biopsy. One of the 6 cores was positive for low-grade cancer. He was recommended to have a radical prostatectomy, and he had one a few weeks later. The surgery was uneventful. He recovered well from that. The pathology was, kind of a mixed blessing. Nothing really unexpected. The disease was intracapsular, but on the other hand, he did have some positive resection margins. They weren't a major problem. He wasn't referred to BC Cancer Agency. Now, when I saw him, we jump ahead to 2005. So at that point, he was referred for what we call salvage radiation therapy. This is radiation therapy in the presence of suspected local disease after surgery. His PSA was somewhat elevated at 0.8, should be undetectable, as you know. His CT and bone scan were normal. His DRE was normal, an empty prostatic fossa. He was otherwise fit and healthy. He was still working. He never recovered any erectile function after his surgery, and he had mild stress incontinence, 1 or 2 pads per day. Now, you know, if you just heard that story, you might think, well, you know, he might have been upset about things, right? I mean, for the last 10 years, he's been impotent and incontinent, mildly so, but nevertheless, irritatingly so. And the surgery that he had 10 years ago clearly had not cured his disease. And he hadn't been referred to consider anything else. So you might think that would be the way that he viewed things. Well, it wasn't at all. It was absolutely nothing like that at all. In fact, what he said to me was, breaking my leg in 1995 saved my life, since they were able to remove the cancer before it spread. Now, how did he come to that conclusion? We came to that conclusion because he constructed, you know, a counter narrative, if you will, a counterfactual. And in the universe that he created, which frankly was entirely imaginary, he was convinced that had his prostate cancer not been accidentally identified in the way that it was in 95, that by 2005, he would have been dead and buried with metastatic disease. So in fact, he created that counter narrative completely out of his mind, right? I mean, he didn't know that. So was it a fair conclusion? Well, the reality is that it could have happened exactly the way that he described it. That counter narrative certainly can happen. It does happen. I've seen it happen. It certainly felt like that to him. And he proudly identified himself as a cancer survivor. And he advocated strongly for universal PSA tests. And in his story, his narrative, the way he told it, the way he felt about it, and it was very real, was that he'd beaten the odds and he was still alive and thriving 10 years out from his cancer diagnosis. I think this is something that many of you can identify with. This story was very important to his psychological well-being. It became a touchstone of his life, really. And I think it is fair to say that prostate cancer has a very peculiar effect. It's transformative when it's diagnosed. This diagram shows that you know, I mean, I guess some physicists would call this our world line through space-time, right? That we go from the past to the future. And if we stop at any point and we call it now, we kind of see an unlimited future for ourselves, with many possible futures, in fact. And it's very reassuring. It feels good. When you get a cancer diagnosis, it's a very transformative event. It actually alters our perception rather of the future. We often see the future as short and truncated. We often see that many of the possibilities that we thought were there for us maybe aren't there anymore, right? And so it is very transformative. And I suspect that for many of you, either as a family member or as a patient themselves, or just a friend, it was transformative for you as well. And it was transformative for me, but in an entirely different way, right? I'll explain later. But I could also create a counterfactual, patient X prime. Same guy, But he didn't fall and break his leg in 95. He had a great trip in Antarctica. In 2005, though, finally, he got around to getting his PSA checked. He was 68 then. The value was 15. There was biopsy, Gleason grade 2 and 3 of 8 cores. The DRE was still normal. Again, he had surgery, same surgery, no problem. The pathology was the same mixed story, intracapsular, but the margins were positive. He recovered well from his surgery. And again, he didn't recover erectile function, and he had mild stress incontinence. So nothing really changed in a way, or did it? I don't know. What did happen is this. He went from this truncated future to this truncated future, which was fully 10 years later. So one way to look at it is say, well, if things had worked out differently, he would have had 10 more years of erectile function. He would have had 10 less years of annoying incontinence. But he would have lost his identity as being a cancer survivor in quite the same way, because by the time we saw him again, he'd be 78 or he'd be older than me. So the real question, though, and the one that we really want to answer is which of these two scenarios is actually more likely? We absolutely know that both of them are likely or are possible. But it does seem important to know which one is more likely. Well, I think you know the answer to that question yourselves if you paid attention to active surveillance and how successful it's been. The second scenario is frankly much more likely. We can never know. It's just a game, these counterfactuals. They're not anything real. These are just imaginary universes we create for ourselves. He could just as easily be right that that's exactly, he would have died years ago and that would have been a fact. So we really don't know about things like that. And the question is, how can we know? Well, let me just try and guide you through some of the facts. This is a huge topic, right? And I can only touch on a few areas. Now, Prostate Cancer Foundation BC advocates for support and education, awareness, and research, and rightly so. I mean, you know, I've just come to realize just how important things like support and awareness and education, how much more important they are than the kind of work I did, you know, as a treating physician. In many cases, it's much more important. But in order to advocate for that, the Prostate Cancer Foundation BC frames their information and characterizes prostate cancer as a major public health concern. Again, rightly so, it is a major public health concern. It has a big footprint in the world, it really does. But think about exactly how it's framed. Well, what I hear is the following. It's the most commonly diagnosed cancer in men. It's the third most common cause of cancer death in men. One in 8 or 9 of us, or whatever the current number is going to be diagnosed with it in our lifetime. And we know that that diagnosis is a transformative event. And we know that a lot of resources go into treating patients that have this disease. These are all true, right? So there's nothing wrong with how they frame it, but it's the right framing if you're an advocate. But suppose you're not an advocate. Suppose you think that it's not very important. How would you frame it? Well, you would point out that in terms of something called quality life years, or even life years lost to prostate cancer, you would find that it's way down the list. Many diseases cause greater loss of life in terms of the person years that are lost. So you could frame it as not so important if you chose to do so. That's the importance of framing. So let's get a little deeper into this then. Now, in terms of advocacy, I always felt, maybe I flatter myself on this, but I always thought of myself as being empathetic and of being an advocate for my patients on an individual basis, making sure that they saw the right specialists, getting the right treatment for them, working as hard as I could to make that happen. You know, as I say, I flatter myself. I'm sure I failed in many ways, but the point is that's how I viewed myself. But I was always really uncomfortable with the idea of advocating for the disease. It felt like it bordered on, well, it bordered on conflict of interest. And that's because prostate cancer is a different thing to you. And when I'm comparing you and me, what I mean is I'm imagining a collective you who are concerned and personally affected by this disease. But that's actually not me. And people would often ask me as if I were some kind of unbiased observer, you know, because very often when I saw a patient in consultation, it was about whether they should have brachytherapy or surgery. Now, in many, many cases, both were equally suitable for the patient. And I would explain the differences. And I would say, but you know, I said, really, the way to look at this is you have two really good choices. And you really can't go wrong with either choice. Things might not go well with either one, but they usually do. And if they do, you know, most people are kind of equally satisfied with either form of treatment. Sometimes they weren't satisfied with that, you know. They say, well, tell me, Dr. Morris, what would you do if you were me in my situation? And I always thought that was such a crazy question. I mean, I didn't say it was a crazy question, you know, I'm not nasty. But I thought to myself, why would they think that? You know, why would they think I was unbiased here? I mean, my whole career, you know, was based on brachytherapy. Did they think I was going to think it was a bad choice or something? I mean, it just makes no sense, right? So how do we start to look at this? How do we get an answer to questions like that? Because that is an important question that we don't have an answer to. What is better? Well, I like to divide it up this way, but this is just me. This is not some scientific way that people like to do this, but I like to think of it this way, okay? Because data, what is data? What's information, right? And I think of it as not just information, but information that could make a difference. So what's an example of a difference? Well, in this context, if we knew, for example, that it was a scientific fact that patients were more likely to be cured by surgery than brachytherapy, let's just say that were true. Well, that would make a difference in the decision-making for a patient. It clearly would. There are other bits of information like, you know, whether well, let's take a kind of an example. Let's say a robotic surgery is better than open surgery. Well, I'm not, you know, the fact of the matter is the information we have on it is they're pretty much the same. So that information kind of doesn't make a difference, but it does make a difference in the sense that as a public health, well, how much money should we put into robots? You know, if it doesn't make a difference, how is that information helpful? Statistics. Oh, statistics. Every time that word comes up in conversation or in discussion, amongst most people. There's an 8 out of 10 chance that somebody's going to give the old saw about, well, you know, there's lies, damn lies, and statistics. I mean, I don't know how many times I've heard that in my life, but I'll bet you've heard it 100 times. And the implication is that statistics are kind of not very reliable. They're deceptive, maybe just outright dishonest. Now, I can tell you that people who use statistics in medicine don't believe that at all. I mean, in fact, totally the opposite. We're absolutely useless without statistics, and we recognize that very well. But there's, and the other thing about statistics is that, you know, people go, well, look, they've done this study and they can't even tell us which is better. Well, actually, that is a conclusion. If you do a good study and you can't tell the difference, that's a very important objective conclusion. So, you know, you don't have to find a difference in a study. That's not important. And negative results are just as important as positive. Finally, there's this thing that I call framing. And framing converts statistics into a narrative or a story, something that you can understand. Like I said, I live in a world of numbers, but most people don't. And you really want to tell a story that people can understand. And you really have to be aware of framing for two reasons. First of all, we all do it. It is universally used. But most importantly, it's subject to incentives. And these incentives can be quite perverse. I mean, they can be financial or psychological, conscious or unconscious, and they lead to motivated reasoning. By that, I mean, you know, we tend to, you know, trust the evidence that supports our point of view and mistrust the evidence that doesn't support our view. This is just human beings and how they behave. So, framing and how it's used is what people actually mean when they say there's lies, damn lies, and statistics. What they mean is there's lies, damn lies, and framing. Now, financial incentives can be quite obvious, right? Let me just give you a quick example from my field. I knew a guy, he happened to be in California, who did a lot of brachytherapy and had a really active practice. And it was one of those practices where, you know, you got to pick and choose which patients because you were just oversubscribed. So you could just charge what you wanted, really, because they were mostly private, not insured patients. And so he just tacked on $5,000 as a surgeon's fee on top of all the other costs that were involved in getting brachytherapy. Now, he didn't do brachytherapy any differently than we did it in Vancouver. It was just the same game. And to give you an idea what $5,000 means in a brachytherapy procedure, I personally have done 4 in one day. And in fact, one of my colleagues, and it was faster than me, did 5 in one day. Now, if you think about that, that was pure before tax money that he was getting just for basically being there and doing the procedure. Didn't count the hospital care, the cost of the seeds, the anesthetists, the charge nurses, all the people. None of that's included. Well, you know, I mean, I don't know how many days a week he worked, but making $4,000 or $5,000, $25,000 a day is a pretty good wage, you know, and it is absolutely bound to affect people's opinion about how good they are and what they're doing. They can't help it. It's just even unconscious. Another example was a guy who did a lot of brachytherapy in the States, and then they recruited him down to a place in Florida because they wanted to get more brachytherapy down in Florida. And this guy had been doing it a long time. He was really good. And he believed in it, and he had a lot of good results. I ran into him a couple of years later at a meeting and asked him how it was going. And he said, oh, I don't do brachytherapy anymore. Well, why is that? I said. He said, well, you know, Jim, he says, I can make 4 times as much with IMRT. And it's just way easier for me to do. And I'm much less likely to get sued for it. And he says, you know, I just got more free time, more money. Why bother, right? So financial incentives are real. And one of the things that I always used to tell my patients when I was explaining about prostate cancer to them and about all the different ideas about how to treat it, is I would say to them, you know, prostate cancer is many different things. I would say, you know, it's potentially a life-threatening disease. It's a major public health problem. It's a concern. But I said it's also a multi-billion-dollar industry. And you cannot really understand it if you don't also realize that that's true. So motivated reasoning is a big deal here, and you don't want to forget about it. So why do we still lack answers to important and basic questions? Well, I mean, the answer here is not complicated. The main answer is this, that science-based medicine is a very, very recent innovation. It's not an exaggeration to say that almost all medical progress that exists today has happened in my lifetime. Probably 98%. It's quite striking, actually. If you go back to twice my lifetime, 150 years ago, I mean, there was nothing. Doctoring was just a show. There was almost no real medicine. Dentistry was pure brutality, right? Surgeons didn't even wash their hands, for heaven's sakes. I mean, if you want to understand what the past was like in medicine, all you have to do is say the following words out loud to yourself. Surgery without anesthesia. That will eliminate any nostalgia you have for the past almost immediately. Well, there is, as I said, a critical difference, between you collectively as people who are directly involved and me. And let's break that down honestly and reasonably, right? Patients, families, friends. Well, you know, they have a direct stake in prostate cancer. It has been a transformative event in their lives. It is potentially life-threatening, and you know, that's just the way it is. It scares us all. They have a deep personal, emotional, and intellectual knowledge of its impact. Me, an oncologist, and me specifically, because it's not true of every oncologist, but neither I nor my family or friends have actually been affected by prostate cancer. At age 72, I'm unlikely to get it because my PSA is really low. So for me, prostate cancer was a source of income and great job satisfaction, international travel and prestige. Let me just stop here at a bit, this prestige part, because it's not just about swaggering around and calling yourself doctor and all that kind of stuff. I mean, you know, all that is kind of there. We get a lot of respect, but that's really not what I mean. Let me tell you what's really good about being an oncologist. Well, there's 2 things actually when I think about it. One is if you're at a cocktail party and somebody asks you, so what do you do for a living? And you tell them that you're a cancer specialist, one of 2 things will happen. They'll either be looking over your shoulder for someone else to talk to, anybody else to talk to, or they start telling you about, their Uncle Sid and the problems he had with getting diagnosed or something, right? So either way, that's not such a positive thing. But I'll tell you what is positive and what is the most positive thing. And that is, you're sitting with an intelligent person like all of you. And they're actually hanging on every word I tell them. How do I mean that? Well, it's a one-on-one interaction I'm having in consultation. I always hear now, and I've heard it recently, that patients say, well, the minute the word cancer came out, I didn't hear anything. Well, I guess that wasn't the case in my practice. I guess mainly because I saw the patient usually a week or two, or sometimes months after they'd been diagnosed. They had some time to get used to all that. So for me, it was not that experience. The experience was they were very, very interested in what I had to say. So think about it. How often do you get, a fellow human being to think that you're so interested that they'll sit there and listen to you for an hour about something? I mean, just let me explain. Like, if I start expounding around the house, my wife rolls her eyes, my kids go, oh, Dad's at it again, the old fart doesn't figure anything out, right? But, when I was one-on-one with those patients, I said, my goodness, these people actually are interested in what I have to say. How amazing. They're paying attention. What's important about that? Well, a couple of things. First of all, it's really addictive, right? And I know what a lot of doctors who weren't really able to cope with that addiction, they began to believe they really were that interesting, that what they had to say really was all that important. And of course, that's a bad place to find yourself. And one of the reasons I'm really glad to have retired and really basically retired. So that's kind of what I mean by prestige. Oops, there we go. Now, I have a couple of advantages over you guys, though, and we sort of illustrated that a bit. You people in the prostate support and awareness group, many of you probably know the narratives of maybe dozens of patients, some of you just a few, but you've heard those narratives. And you understand me, there's quite a range of responses to this disease. But there's two things wrong here. One, it's still pretty limited range. And the other thing is that just a tiny fraction of all the patients that are diagnosed with prostate cancer ever attend one of these meetings. Now, that's really too bad, because many more patients would get a lot more out of these meetings, right? But they just don't. They're a self-selected group. And so what you hear from prostate cancer patients is not necessarily typical. Now, me, on the other hand, well, I've treated thousands of cancer patients, and about 75% of them had prostate cancer. And I really have seen pretty much the full spectrum of disease, from the most indolent cases to the most rapidly progressive and fatal. And you can't quite share with me that same experience, right? So getting back to our question, what is screening? Well, it's searching for signs of disease in people who are experiencing those symptoms of that disease, right? What's the purpose of it? The goal, if you will. Well, it's to reduce the mortality of the disease in question. It's a very specific thing. It's not about early diagnosis. It's about reducing the mortality of the disease. And you don't want to confuse those things, because they're quite different. How do we know if screening has been effective? Well, you get fewer disease-specific deaths in the screened population compared to the unscreened population. But for that to be true, even potentially true, there have to be two important requirements, right? You have to have a reliable test for asymptomatic disease. You also have to have effective interventions that will reduce the death rate from that disease if they're done, right? So how do we scientifically evaluate screening programs? Well, fortunately, in some cases, it's just common sense logic and basic death statistics can be adequate, actually. So, I mean, to be facetious about it, as doctors often are, you don't need a randomized trial of parachutes, to find out that your odds of survival when you fall out of an airplane are better with one than without one, right? It's just, common sense. And you don't really need to go much beyond that. Well, we have an example like that. Pap smears, cervical cytology for cervical cancer in women. This, BC played a very major role in the rolling out of effective cervical cytology, and it is world famous for that. But once this became introduced in separate jurisdictions, the mortality from cervical cancer was dramatically reduced in many separate jurisdictions. I mean, it was just a no-brainer. It just had to be a great success. But sometimes common sense, logic, and death statistics just don't suffice. And then we have scientific medicine, and that requires evidence. But what is evidence, right? That's always a puzzle. And, doctors have their little pyramid of evidence and all that, but let's just think about it for a minute. What is evidence? Are stories and testimonials evidence? Are examples like my patient X, is that evidence? Well, no, it just absolutely is not evidence. It's an important story. It was a very important story for that individual. What about expert opinion? What about a famous Dr. X tells you, well, in my opinion? That's not very good either, to be honest with you, because you don't know how he's framing it. You don't know what his incentives are. Somebody's coughing. I don't know, but anyway, sorry. But you don't know what his incentives are. What about the consensus opinion of many experts? Well, that gets up a little bit higher. What about single-arm studies? Well, we treated 8,000 patients with brachytherapy, and this is how they did. Yeah, that's a step up. But again, it falls short of the gold standard. The gold standard, of course, is a randomized study. And multiple randomized trials are actually required to be totally convincing evidence. And we just don't have a lot of those. And we work hard to get them, but they're really, really hard to do. And I'll touch on that in a bit. Well, let's think about, when you think about screening, a really good example is breast screening and mammography. Now, it's a fact that mammography can detect smaller cancers than physical exam. It is also a fact that early detection of breast cancer reduces the mortality of the disease because we have effective interventions, surgery, radiation, chemotherapy. All the ducks are lined up in a row. So, mammography and breast cancer screening, it should be a slam dunk. There should be no problem. We should be able to prove it. It should be a done deal already. Well, the fact is, it's still controversial. Even though randomized trials have proven benefit. Why is that? It's a bit complicated. For example, not all the trials were positive. And the value to women is subject to framing that alters its importance in a way. So let's think about that. If you're an advocate, if you're of mammography, and that might be because it saved your life or your mother's life, or because you happen to be a diagnostic radiographer who specializes in mammography and wants to set up a mammography clinic. I mean, it could be those kind of things. It could be all kinds of things. You would frame it this way. You would tell the patient, you'd say, look, randomized control trials have shown that mammography can reduce a woman's risk of dying of breast cancer over the next 10 years by as much as 30%. Now that sounds like a no-brainer. Sign me up. I'm getting mammograms. I mean, 30%, that's huge. You know, if you wanted to minimize its value, you might point out that the observed reduction is from 0.3 to 0.2%. What does that really represent? Well, it means that in that 10-year period, in the unscreened population, we would expect 3 deaths for every 1,000 people from prostate cancer. But if we screened them, we would expect 2 deaths for every 1,000 people with from prostate cancer, from breast cancer. If I said prostate before, please excuse me. It's breast cancer, obviously, in both cases. Now, that's still a big deal. I mean, 1 per 1,000, that's not trivial, but it doesn't have the same emotional impact to most of us as 30%, even though the same statistics are used in both cases. That's the power of framing. Again, I think it's critical. Well, what about PSA screening? Is it a slam dunk? Well, it isn't. And I'm not going to run you through all the clinical trials and things that have been done to try and demonstrate whether early diagnosis and all that sort of stuff. It's just stats and figures and blah, blah, blah. But you may not believe this even. But we oncologists have yet to demonstrate scientifically to anyone's or to most people's satisfaction that early diagnosis and treatment actually increases the disease-specific survival. Now, I don't know whether that's common knowledge or not, but an awful lot of people believe that it does, but we haven't actually been able to scientifically prove it. Why is that true? Well, there's a lot of reasons, right? Some of them are just the cliches about prostate cancer. It's a slow growing disease and, it's indolent in many cases, and all that's true. That we have remarkably effective treatments for advanced metastatic disease. And they're getting better, pretty much every year. If I recall, when I was last in this, if somebody walked in off the street with their bone scan lit up and they had a PSA of 1,000 and they never and they were in pain and misery, the average life expectancy for that patient with prostate cancer would have been about 4 years. And that's out of date. It's longer than that now. And some live to be 20 years beyond that, right? Of course, some only lived a few months too. But if it was, cancer of the pancreas, cancer of the lung, most of them don't live 4 years. Occasionally they do, but that's truly an uncommon event. It's not an uncommon event in metastatic prostate cancer. And the other fact is that the age at diagnosis is, 10 to 12 years later than it is, say, in breast cancer, which means the number of years of life lost is going to be less. And it also means that, people my age, I'm 72, there's a lot of other causes of death out there. And they're just, when we say competing, it's not like they're all waiting to get you or anything, you know, competing with each other. It's just a fact that, you know, none of us get through this thing alive. And, you know, so the odds of dying of something else before that prostate cancer gets you, it's just not as high as it is for most other cancers. Well, somebody brought up the ASCENDE-RT study. I'm sorry. And because I am the principal investigator for that study, and the fact, I've got to move something on my computer if I can here. Let me get this out of the way. I'm going to show you a couple of graphs from that just because I think it's kind of interesting and demonstrates a point. Now, these graphs are from a 10-year update, which we've just submitted. In fact, last week, it's just been accepted for publication. So ASCENDE-RT is an acronym, and it stands for androgen suppression, or ADT in the terms used, combined with elective nodal and dose-escalated radiation therapy. And we dealt with very high-risk patients. So these are the ones that are much more likely to die of prostate cancer if their disease is localized than the patients that we put on active surveillance, right? They have a much shorter average life expectancy from the disease. And what we did was we randomly assigned them to get a brachytherapy boost or an external radiation boost to the highest dose that we were able to give. And what this graph shows is a big separation between the two lines. Now, what does this graph actually show us? Well, it shows us that at 10 years, the brachytherapy, about 85% of the patients who were randomized to receive brachytherapy were free of any evidence of recurrent disease. So their PSA was usually undetectable, and they had negative bone scans, DREs were normal, all those things were normal. But it only applies for the patients who were still alive, right? So some of the patients died along the way of other things. They had heart attacks and one suicide. I remember we had people die in car accidents and liver cancer and you name it, right? Everything you could think of. So it only applies to the patients that were still alive 10 years later. If they had external radiation, it's only about 65% of those patients were actually still free of disease. And it continued to decline thereafter. Now, this is as good a separation in lines as you'll ever see in a randomized trial of prostate cancer. It's hard to get this much effect. It's a huge effect. It's a doubling of disease-free survival. But here's the fact, in spite of that, in spite of a very good result, if we look at, I can't go to the next slide. What's going on? So maybe this will go up here someplace and I can, there, no? Okay, there we go. In spite of that fact, this is the actual survival curve. Same colors, the gray one is the brachytherapy arm and the black one is the high dose external beam. And you can see that at 10 years, basically the same number of patients are actually alive. So what this tells you is even if you have a dramatic improvement in what appears to be long-term cure for this disease, you're actually not that likely to see any actual improvement in survival. Or at least that improvement is small enough that you'd have to test thousands of patients to actually see the improvement, because it's going to be 5%. It's not going to be a doubling of survival. Now, that's a really big problem, right? And what else made it difficult to do this trial? Well, this trial started accrual in 2002, and it completed accrual in 2011. And 400, well, actually 398 patients were accrued to the study, basically 200 in each arm. Now, that seems kind of strange. I mean, that's only like 20 patients or 40 patients a year. Well, that's kind of weird because this was open in 6 centers at the peak. And collectively, we saw at least 1,000 patients a year that were eligible to be in the trial, that would have been good candidates to be in the trial. And there were also at the centers, and there were also another 1,000 patients every year that were equally suitable, but were never even referred to the BC Cancer Agency or to the Ontario centers. So a very tiny fraction of all the patients that were eligible actually could get into this study, mostly because nobody even told them about it. Nobody gave them an opportunity to be in the study, but also, believe me, patients don't like randomized trials. So I'm going to summarize and stop here and answer questions. Let me just say that science-based medicine is new. It's still poorly integrated into cancer care and other areas. And it's difficult. It's really, really difficult to do in terms of time and resources. Only a really tiny portion of cancer patients are enrolled in clinical trials. And there really doesn't seem to be any movement to alter that. People talk about it, but practical suggestions are pretty hard to come by. Good quality data to make decisions in general is just really often absent altogether. I find this a bit shocking. This is one of the things I get kind of upset about. You know, here in BC and other places in Canada, we have a publicly funded healthcare system which provides state-of-the-art cancer care to patients. And in fact, if you look at the stats in Canada in general and BC in particular, you'll see that there's no place that does better than we do, actually. But we don't actually systematically collect data. We have no foresight. You know, if you wanted to find out how many patients are cured by prostate surgery in BC, you'd be right out of luck. There's just, you know, unless you had a lot of money to spend and a lot of time to spend going through charts and trying to correct for all the reasons that the data is incomplete, you'd really be just plain out of luck. We did publish a paper some 10, 12 years ago that showed it. But again, you'd say, well, that was 12 years ago. Things have changed. Maybe they have. We don't know, right? So we use the imperfect data that we have in a way that supports our agenda. And we tend to ignore or minimize data that contradicts our agenda. That's just the way we are as people. And doctors, they're people too, you know. I mean, I know the old joke, what's the difference between God and a doctor? Well, at least God doesn't think he's a doctor, right? But we really are just people, and we are no more, and in fact, many cases, less objective than you are. So we frame the statistics to create a simple narrative that supports our agenda. And, you know, scientific medicine, science-based medicine is designed to be the way that you can prevent yourself from fooling yourself. Because remember, you are the easiest person there is to fool. Thank you. That's the end of my talk.